Professor Christensen is the best-selling author of numerous books, including his seminal works, The Innovators Dilemma, The Innovator's Solution, and Seeing What's Next. Christensen has focused the lens of disruptive innovation on social issues such as education and healthcare. Disrupting Class looks at the root causes of why schools struggle to offer solutions, and The Innovator's Prescription examines how to fix our healthcare system. On the personal side, he has been an inspiration to leaders all over the world through his writings, including his best-selling book, How Will You Measure Your Life? Professor Christensen has been a missionary for the Church of Jesus Christ of Latter-day Saints and speaks fluent Korean. He has served the Boy Scouts of America for 25 years as a scoutmaster, cubmaster, den leader, and pack chairman. He is the father of 5. There could be no better speaker to address leading patient safety innovation than Clayton Christensen, who has suffered from type 1 diabetes, cancer, heart attack, stroke, and pain syndromes related to his treatment. He has suffered preventable adverse drug events with all 3 of the big 3, diabetic agents, anticoagulants, and pain medicines. The theory of disruptive innovation was first coined by Professor Christensen in his research on the disk drive industry, popularized in his book, The Innovators Dilemma, and its use is credited with helping generate more than $20 billion in new revenue for the Intel Corporation. The theory explains the phenomenon by which an innovation transforms an existing market or sector by introducing simplicity, convenience, accessibility, and affordability, where complication and high cost are the status quo. Initially, a disruptive innovation is formed in a niche market that may appear unattractive or inconsequential to industry incumbents, but eventually the new product or idea completely redefines the industry. In the introduction to the Innovator's Prescription, he defines the 3 elements necessary for disruptive innovation in healthcare. Number 1, technological enabler. Typically, sophisticated technology whose purpose is to simplify, it routinizes the solution to problems that previously required unstructured processes of intuitive experimentation to resolve. Number 2, business model innovation. Can profitability deliver these simplified solutions to customers in ways that make them affordable and conveniently accessible? And 3, the value network. A commercial infrastructure whose constituent companies have consistently disruptive, mutually reinforcing economic models. In the middle of these 3 enablers are a host of regulatory reforms and new industry standards that facilitate or lubricate interactions among participants in the new disruptive industry. Interestingly, his Disruptive Value Network design, published in 2009, depicting how personal electronic health records and high-deductible healthcare plans will evolve with data flow, money flow, and employer contracting, is actually happening now in 2015.
Clay, we're so excited that you're speaking to this audience. This audience has been convened to focus on leading patient safety and leading innovation in patient safety, your passion.
I'm just delighted to be with you and with your colleagues there. I wish I could be there in person, and I apologize, but this is the next best thing, so thanks.
Well, it's great to have your book to go by for this group, The Innovators Prescription. And now 5 years later, it's amazing how so many of these disruptive innovations are in process.
Yeah, that's what we had hoped to do. And we've learned a few things, from the experiences of writing and then teaching about the principles in the book. And a really important one is that if we hope in any way to change the way our healthcare is delivered, we have to have a common language, and we have to have a common way to frame the problem. And if we get there, then we can reach consensus around even counterintuitive courses of action. But if we try to solve the problem without having a common language, we'll just never get there from here. And there are a few ideas and a few pieces of language in the book that I think have, moved the work ahead. And for that, I'm just very grateful.
It's been so wonderful to work with you over the years and have you teach us how to use theories as a lens. Can you describe that for us?
Yeah. Well, you know, the word theory gets a bum rap with professionals because it's associated with the word theoretical, which connotes impractical. But anytime any of us takes an action, it's predicated upon a theory in our mind that if we do this, we'll get the results we need. Or every time we put together a plan of action, it's predicated upon one or more sets of theories about, because a theory is a statement of causality, of what causes what and why. And so we put together this plan that's predicated upon theories. And the nice thing about a theory is we can predict in advance whether our action will get the results that we need. And so that's why we focus so much on developing good theories, because we use theories anyway, and gosh, I hope that they're good.
Your story about how this all started, I can remember asking you about the lens theory sort of concept, and you shared the story of Andy Grove and Intel. Can you share that with our audience?
Yeah. So I was in my office minding my own business just after we had published the first academic piece about disruption. And Andy Grove called me out of the blue. And I'd never met the guy before, but he said, an engineer in my company read something that you wrote in which you predicted that Intel is going to die. And I got to talk to you about this. And I said, forgive me, but I know nothing about Intel. I never said that you were going to get killed. And Andy said, well, an engineer said that he read it, you know. So, but for me, it's a chance of a lifetime. He invited me to come back in a couple of weeks, and he had all of his direct reports that were going to be in this meeting. And so I showed up a little ahead of schedule, and at the break, he said, Clay, we just don't have time for you. It's a busy day. So thanks, but no thanks. And then he said, you know, but you've come all this way. I'll give you 10 minutes to tell your research and tell us what it means for Intel. So I did my best to summarize the theory of disruption for Andy Grove and the team. And when I was 5 minutes into it, he cut me off and he said, look, I got your stupid theory. Tell us what it means for Intel. And he summarized what he got, and he really did get it, you know. And then I said, Andy, I just need a little bit more time to explain how this process of disruption worked its way through a completely different industry than yours so that you can visualize how it works. And so I told him about the steel industry. And it described how the integrated steel companies were making all of their products, but mini mills that melt scrap in electric furnaces came down at the bottom of the market going after rebar, and then made progressively more sophisticated steels so that they could hit the high end of the market making sheet steel that's used for cars and trucks. And when I finished that story, Andy Grove raised his hand and he said, this is exactly what's going to happen to us, isn't it? And he pointed at the bottom of the market and he said there were two companies there, AMD and Cyrix, and they are to them what the mini mills are to the sheet steel companies. And what it tells me we need to do is we've got to create a separate business unit and target it to kill those two companies, or they're going to kill us. And I just was stunned, you know. And I was talking to Andy about it years later because that year Intel had launched new products guided by this theory of disruption that accounted for more than $20 billion in revenue. And I asked Andy, how did he pull it all off? And he said, you know, having a theory gave us a common language and a common way to frame the problem so the whole management team could reach consensus around a counterintuitive course of action. And that's what we miss when we don't have a theory. If you just have data, data never converts anybody. It strengthens people's pre-beliefs, faith in whatever. But a good theory changes people's minds.
So Clay, in your book, The Innovator's Prescription, you describe at the outset the theory of disruptive innovation, and it has been much maligned and it's been much misquoted, and I think you did a beautiful job in the book. We recommend it to everybody. Can you walk through the elements that are described on page XX on 1.1, figure 1.1?
Okay. I'll do my best. So, we don't ever use the term innovation anymore because it's such a broad rubric. But there are types of innovation. And some of these innovations are just critical for transforming healthcare. There is one concept called sustaining innovations. And sustaining innovations make good products better. Almost all innovation in healthcare is of that nature, because we're always trying to make good products better so that the caregivers can do more efficacious things. But although those are good, they don't transform the industry. What we need are innovations that are sophisticated technologies that make challenges simple. So, for example, rather than expecting that our hospitals will become cheap, what we need are technologies that enable us to do things in outpatient clinics, the simplest of the things that today we have to address in a hospital. And then we need to drive technology into a clinic so that it can do progressively more sophisticated things. And then we need to bring technology to doctors' offices and then the pharmacies so that they can do the simplest of the things that today you have to address in a clinic. And then keep driving the technology so they can do more sophisticated things. And in a similar way, rather than hoping that the specialists will take pay cuts, we need to bring technology to nurses so that they can do the simplest of the things that today a doctor has to do. And then we need to just keep driving technology into the nurses so that they can do progressively more sophisticated things. So innovations that the way you make healthcare affordable and accessible isn't by expecting the expensive ones to become cheap, but rather use technology that simplifies through technology so that lower cost venues of care and lower cost caregivers can do progressively more sophisticated things. And that's how we make it work in healthcare. And to this time, until we wrote the book at least, we really had very few examples of sophisticated but simplifying innovations that drive costs down.
So when you describe disruptive innovation in healthcare, you describe three elements. One is the technology that simplifies, and then the second is economically coherent value networks or a value network, and then the third are low-cost innovative business models. Can you describe a facilitated network? Because this is a great concept that most people really need to understand.
You know, when we teach our doctors in medical school how to give care, we teach them as an individual caregiver how to deal with the patient. But what we don't teach them is that you actually have, you're surrounded by processes and structures and organization charts and budgets and so on. We don't teach our doctors that they're surrounded by this stuff. And what's worse is we have supply chains, people who develop and deliver to us drugs and devices. And then we have to take care of the doctors or the patients after they leave. And a value network is a group of people before us, in the middle of us, and after us that are coordinated in a way that brings costs down. If we think that we as an individual player in a system can make a difference, we don't understand the way the system really works.
Then the third element that you describe are the low-cost innovative business models. And I think it's so important for us to understand that the competition within a business model and the importance of new ones. And now we've got pay for performance actually happening, so we see the business models changing.
Yeah. It's, this might be one element of the healthcare system that is resisting change more than others. And if you look at what is the cost in a hospital, somewhere around 85% of the cost is in overhead. And overhead exists because the processes of getting things done are not efficient. And so things fall through the crack. You don't know where this has gone to. This takes 3x more time than it has been allotted. And we have all of this overhead structure, and it exists because we don't figure out how to make it simple and affordable in a process. And we really need to worry about that. Most hospitals have a sign on the front cover of the hospital that says, you know, guys, it doesn't matter what is wrong with you, bring it in here. We will solve any problem for anybody. And that's what a hospital tries to do. But because we try to do everything for everybody, it's very hard to get overhead costs down. And a low-cost business model entails delivering care without all of that overhead. And the way you do that is you focus the hospital to do one or two things very, very well. So that what it means is we need to have fewer general hospitals and more focused hospitals, because they provide that, they provide low cost and high quality care.
So Clay, everyone has seen the Forbes article about you being the survivor and having these major disease processes and being able to survive them and excel despite them. You've had a personal experience of the issue of care coordination, and this audience is focused on that system failures are a major area where we need innovation and patient safety. Can you address your personal experience?
Boy. Well, I have had a lot of experience with the healthcare system. In the last 10 years, I've both of my retinas at different points disengaged. I've had type 1 diabetes for 38 years. I had a horrible heart attack about 9 years ago, and a year after that I was diagnosed with follicular lymphoma. And then a year after that I had a stroke that caused me to be unable to speak, and now I have some systemic problems with my nervous system. So it's hard to find of anybody who's have more experience with the healthcare system than me. And I am very grateful for the caregivers that did everything they could to help me. So I don't mean to say, to speak in any way disparagingly about how good they are, because they really just killed themselves almost just to save my life. But it's very hard if you're an individual caregiver, to coordinate anything, because everything is a one-off. So this patient comes in, he needs this coordination and not that. And so you do that in a one-off. And then another patient comes in and they need different they need to be coordinated with somebody else, you know. And so it's very hard for processes to emerge if you don't ever do anything more than once, you know. And that's the challenge in the way we organized the delivery of care, where if the caregivers are independent actors and they get reimbursed by individually provide care to the patient, they might do a great job individually, but the system doesn't coalesce around a way to do it over and over again at ever higher quality and ever lower cost. And so I just am so grateful for the caregivers. But boy, we have put them in a system where the current is going against them in whatever direction they swim.
And you've had the experience of real team-based care, of your caregivers working together, and then you've been in environments where they didn't. Our patient safety leaders really need to focus on the team-based care and having the right information at the right time for the right patient for the right decision. You've really seen that pay off, haven't you?
I truly have seen the benefits of it. So our system in Boston is organized around individual caregivers. And if I need to see 2 doctors to get their perspective on my stroke, for example, boy, it takes sometimes months to get those 2 calendars to put together. And I'm a busy guy too, you know. And at the other end of the spectrum, we spend a week at the Mayo, and everything there is organized around a team. They've worked with each other before. They know each other's capabilities and their preferences, and they know how to communicate with each other. And it was a delightful event. I don't know how much, what the cost, I paid for it myself because I wanted to feel the cost of that experience. And it was actually much cheaper for me than it was had I done that thing, coordinating individual caregivers in Boston.
In your book, 5 years ago, you have a diagram in the introduction that puts the patient's personal health care record that they control right at the center of the diagram.
Yeah.
And recognize that it would be very important for us to have these electronic technologies. And so many of us know that this is a major area of patient safety because we need to do 3 things. One is we need a safe system. And then number 2, we need to operate it safely. That's a challenge. And then the third benefit is that if you can have a safe system that you're operating safely, you can use it for patient safety. And our folks really need to use that. And your advice to us that you predicted what's actually happening, and it's in your introduction.
Well, I'm just delighted that it seems to be working. You know, by analogy, Toyota just came to North America with just better cars. They were safe. There weren't any lemons that they produced, you know. And General Motors tried to counter Toyota by creating an IT system where they collected data on every car as they were going through the factory. And then from this central computer, they would dispense what to do next on every car. And essentially what they did was they created a very hierarchical IT system because the problem was very complicated. So a complicated problem merits a complicated solution, was the idea. And looking back on it, Toyota's approach was, this is a very complicated problem. We need to simplify the problem. And they decided that they needed to have all of the data required to build the car that was on the car as it flowed through the process. And that idea that we need to have all of the information flow through the process made so much more sense than all of the overhead that is that you build in a General Motors kind of a mode. And it simplified a complicated problem. And now the next step is, if the information flows with the patient, then actually that information can be the provider of coordinated care. As if you don't have that data, then you have a doctor who doesn't know every dimension of the system. And then if he tries to get it from the local computer, sometimes it's just not there or not right. And the idea that the information flows with the patient and it's good enough that it can do much of the coordination of care, I think is a very exciting idea.
So you're a big champion for patient-owned and patient-controlled healthcare records.
Absolutely. Absolutely. I can't imagine that it would work without it, Chuck.
3 of the most common and preventable adverse drug events are areas you have a lot of experience with: anticoagulation management, diabetic agents, and pain management. We understand that 60% of these actually cause the major issues that we have in adverse drug events. Your thoughts there in challenging us to focus on fixing these problems?
Great question, Chuck. I'm not sure that we got this right in writing the book, but it's clear in my mind now. And by analogy, I haven't died yet, so I really don't know what it's going to be like, you know. But I'm imagining that they're going to interview me. And when we sit down for the interview, my plan is to say, I know you have a lot of questions for me, but I have a lot of questions for you, and if you wouldn't mind, I'd like to go first. And one of the questions I'm going to ask is, when you organize the world and you put us on the earth, I think you miscounted, because you didn't give us enough symptoms to go around for all the diseases that exist. They just don't match. And because there are, in fact, so many more diseases than we have symptoms, the diseases had to get together and agree to share symptoms. And that created a lot of the problem in healthcare. Why did you miscount? That's my question. But it's not a simplistic problem, because when a caregiver sees a symptom, their instinct is, oh, I've seen one of these before. Like, I've seen type 2 diabetes before. Here, take metformin, because most people need metformin. But from the patient's point of view, there are actually more than 12 diseases that we call type 2 diabetes. And if I don't know what type of type 2 you have, then the probability that I'll give you the wrong drug is actually not insignificant. And I think that in our system historically, and I think this is driven by not good thinking on the part of you of the NIH, but also healthcare companies, or insurance companies have been bad actors here. They have rarely rarely given reimbursement for activities to figure out what type of type 2 you have. We underinvest in identifying the problem, and we overinvest in providing the solution.
What a great thought. And part of the solution is the patient and patient education. And we know that patient advocates have been screaming for being involved in shared decision making and engaging them in the education piece. And is it true that you would not likely have had your stroke had you understood more about anticoagulation management?
I think it could have prevented my stroke had I had the education that I needed. So I had a heart attack. It periodically went into afibrillation. I was given Coumadin is the prescription. And then I had to go to, on business to Asia, and I ran out of Coumadin. I ran out of Coumadin. And my heart started to go into afibrillation. And I didn't understand how those things put together to create clots, which then cause strokes. And I don't know, maybe it would have happened to me anyway. But I needed to understand not just what to do, but why I had to do it, and what could happen if I didn't do it. And I think it could have prevented something that has just been a real difficult impact in my life.
It's no big surprise to know that most patients, in fact, half of the patients that take Coumadin stop taking it after 2 years for no reason. We don't understand it. It may be routine or habit or whatever, but you're not alone, and that's where we really know involving patients and families are so important.
I'm a convert. I absolutely am a convert.
So Clay, in the diagram in your book, you put a personal health record, patient-controlled personal health record right at the center, and it's amazing how this is evolving. Are you still a champion of that?
Oh, absolutely. I'll tell you, Chuck, anything that is hierarchical adds overhead cost. And everything that flattens simplifies problems. And just like Toyota deciding that all of the information required to assemble a car flows with the car, the analog with our health is exactly the same. The more that information can flow with us as patients, the more understanding we are of what's really going on with us, but also is available for the caregivers so that they can do the right thing at the right time.